Thank you everyone for joining us today. My name is Jackie Garlock. I'm with the Community Technical Assistance Center. Welcome everyone to today's webinar, Dialectical Behavioral Therapy 101, from inpatient to community care. So you'll note that upon joining the webinar, you've been placed on mute. If you'd like to activate closed captions for the presentation, I see some of you have already done that. You can do so by clicking the button on your toolbar. It says live transcript, and then you can select show subtitles. If you come across any technical issues during today's event, as we can see, that is part and parcel of being part of technology these days. You can always chat to either myself or to my colleague, Leslie Giglio, and you can, she's under CTAC admin, and we can help you as much as we can. We're going to have a Q&A portion at the end of today's presentation, but we're going to ask that all of you use the chat box feature throughout the presentation today to chat your questions in, and then we'll, consolidate those during the Q&A portion. We're going to also, we would really appreciate if everyone take a moment at the end of the webinar to fill out a brief feedback survey. It will appear on your screen after you close out, and it will also be available to you via email if for some reason you're unable to access it. And the recording and presentation slides for this presentation will be posted on our website, ctacny.org, within the next 2 to 3 business days. I am delighted to introduce you all to today's presenter, Dr. Sophia Moras. She's an experienced and accomplished child and adolescent psychiatrist and serves as the medical director at 3 East, an adolescent dialectical behavioral therapy program at McLean Hospital in Belmont, Massachusetts. Welcome, Sophia. And I realize I'm not sharing my screen, so I'm going to bring that up as you get started.
Excellent. Thank you so much, Jackie.
Okay, here we go. Fantastic.
Thank you so much for that. Excellent. Thank you so much for that introduction, Jackie. So in today's presentation, we're going to go over dialectical behavioral therapy. We're going to look at the core DBT strategies, as well as the inpatient to community care, and what this looks like across systems. Before we delve in, I have to share with you guys that as I was preparing for this talk, I thought about my first year out of medical school when I was an intern working on the medical floor. So even in our psychiatry residency, we have a rotation where we focus solely on internal medicine, where we deal with people's asthma exacerbation, diabetes, hypertensive injuries, and sometimes occasionally we do get a psychiatrically ill patient. And I have to tell you, in that setting, this was really challenging because we have 12, 13, 14 patients that we had to see by 7:30 every morning, while making sure that we've done all their physical exams, looked at the lab work in time to present to our senior residents. And I think about those times because in that setting, it was quite hard. And it made me think about how we're doing the best we can and we could do better. In a different setting, when I was doing my psychiatry rotations, where the expectations were different, seeing a psychiatrically ill patient was a totally different endeavor because the expectations were different, the timing was different. I wasn't trying to overdo everything in 2.5 minutes. So with that, I'd like us to think about how this presentation can give you something that empowers you, that helps you feel more prepared to meet some of these challenges. Dialectical behavioral therapy is really a comprehensive approach that's meant to help adults and young people over the age of 10. And the focus is really on a population that tends to have difficulty regulating their moods, as it was originally designed for people who are chronically suicidal, usually dealing with borderline personality disorder. And the dialectical part refers to the recognition and the synthesis of opposites, or at least ideas, thoughts, concepts that feel that they're really in contradiction with each other. And the purpose of this therapy is finding the synthesis, the middle ground, a way of integrating things that feel opposite in a way that represents the whole reality. This therapy was originally developed by Marsha Linehan in the 70s. She found that using a very change-based therapy like cognitive behavioral therapy didn't work. Patients felt that they were being pushed to change before being fully understood. They were discouraged. They actually felt more suicidal and had a really hard time participating in this treatment. When Marsha Linehan looked at more acceptance-based therapy, more mindfulness-based therapy, this actually also didn't work, and they got worse because they were stuck in a place of acceptance and resignation of their suffering versus feeling like progress was happening and they could move forward. So the synthesis, the dialectic, if you will, that Marsha Linehan realized was focusing on bringing those two things together, how to simultaneously push for change while also providing patients with the acceptance of their current condition, a recognition of their suffering in a way that made them feel heard and supported, while also guiding them in a place that took them out of the suffering and made them much more capable in addressing their distress in constructive ways. So as we go forward, it's important to think back about some of the theoretical framework that Marsha Linehan used, one of them being the biosocial theory, really recognizing that a patient's presentation is the manifestation of that interaction between what they bring to the table biologically, their genetic predisposition, really focusing in on patients who were much more sensitive, people who were much more reactive, who felt deeper, much more intensely, and had a harder time returning to baseline, who unfortunately exist in environments that were highly invalidating. And this is not necessarily invalidation that is necessarily traumatic, but invalidation in a way that didn't recognize their suffering or didn't recognize their sensitivity. So that combination, what they were bringing to the table and the environment they were being raised in, where they were interacting, really came together to create essentially a perfect storm that resulted in the presentation that we're seeing. This is an important point because as a child psychiatrist, I'm often met with parents who wonder, why is my child like this? What did I do to create this situation? When in fact, it's a complicated picture that we have to take both sides into account and realize there is a biological predisposition that is interacting with, excuse me, there is a biological predisposition that is interacting with an environment. Excuse me. The second important theory is the behavioral theory. It's a recognition and understanding that all behaviors are caused, that they're antecedents, meaning events, constructs, feelings, factors leading up to a person's behavior, and then there are consequences that are the downstream effects. This is important because we need to realize that when we see someone's behavior, it's not happening in a vacuum, that what we're seeing is an accumulation of various vulnerabilities that are leading up to this behavior. And we're recognizing that there's a very real cost in terms of the consequences. We hold this in mind, and we also consider that behaviors are maintained when they're being reinforced. Behaviors are maintained when they serve a specific function, even if on the surface these behaviors appear to be problematic or maladaptive or ineffective. Because they serve a function, they are maintained and may be hard to let go of. So one thing this brings to mind was when I worked with very young patients, I had a 4-year-old, and I remember on a Friday night, a mom calling me and saying, Dr. Moras, we absolutely have to make a medication change for my son. And she called me in a lot of distress, saying that her son was out of control, that he had bitten his dad's shoulder. So one perspective is, this child is demonstrating really aggressive behavior, now is, biting a parent. There are ways of addressing this that as a young trainee, I could have, looked back to my psychopharmacology supervisor and said, okay, how do we make a medication change to address this? And instead, when I spoke to this mom, I said, walk me through how we arrived here, right? What were the antecedents leading up to this behavior? It turns out that before this biting incident, this child was sitting at a restaurant with his parents, and the parents had bought a toy for the kid. And the parents said, you know, in order for you to play with your toy, you need to complete your meal, which sounds reasonable enough. Well, this 4-year-old decided that he wasn't interested in finishing the meal and wanted to play with the toy. When he wasn't given this toy, his behavior escalated. He got really distressed. And dad's response was to pack up the toy, pack up the family, and put them in the car. Now, this kid who really wanted the toy decided, well, I can't have this toy, and really proceeded to cry, yell, and scream as he's sitting in the car seat. Dad's becoming more distressed, and finally he stops the car, takes the toys, and throws them away. The kid sees this and really becomes even more distressed. By the time they get home, the kid is really dysregulated. Dad picks up the kid from the car seat, and the kid bites him on the shoulder. So this is really an example of how we arrive in a place. And if we're just sticking to that initial presentation of a kid biting their parent, we could say, oh, they're dysregulated, their medication regimen isn't working. That's potentially true, and that behavior is not actually happening in a vacuum. So I want to pause there and move over to dialectics, because that reality that I just described actually contained both dad's perspective. The wisdom in his perspective was, you know, wanting to make sure that his child completed the meal as part of a balanced diet and making sure that he was healthy. The child's perspective is also important, because here's something that he really wanted and it was being taken away from him. And his recourse was in escalating that behavior through screaming and expressing distress. So there's wisdom in both parties' behaviors, and they're connected because we see as the kid escalated, so does dad, right? That there's an interconnection between the two, even though they're sitting on opposite sides. But it's important to consider both sides to actually have the whole picture. So DBT is important because it helps us find out sentences and use skills and resources much more effectively. We can use these to overcome specific treatment barriers that could range from poor motivation, anger, depressed mood, and inability to move forward from the distress in a way that doesn't make things worse, right? So the use of these skills not only helps us reconcile those binaries to see the wisdom in both sides, but it might expand the window of tolerance by giving us better coping skills when we are in distress, because we are all doing the best we can and we can do better. This is really a central theme in DBT. This method has been found to reduce hospitalizations, depression, anger, suicidality, and especially self-injurious behaviors, and help people remain in treatment because they're having the experience of being both validated and being coached in a way that gets them from their current state to a much more adaptive stance. The goal here, as I said before, is to really increase the client's motivation to change. It is not uncommon for patients to find themselves feeling very hopeless and helpless as they're stuck in a vicious cycle of experiencing their stress and responding in a way that might provide relief in the moment, right? Or pushing aside the aversive emotions in a way that gives them a break and then having to deal with the consequences. So, for example, even the self-injurious behaviors that we see as maladaptive may provide some relief in the moment, which is what fuels the behavior and maintains the behavior, because the wisdom in this behavior is that brief relief that's gained, and not feeling like there are other options that will provide a similar impact. So there's quite a bit of hopelessness and helplessness, and one of the functions of DBT is increasing that motivation to change by helping patients recognize what's in it for them to make a change and to help them feel understood and heard while we're considering this change. We enhance the patient's capabilities by giving them other options, because the idea is if patients had the skills, they would do better. They are absolutely doing the best they can, and with skills and the right support, they can do better. And it's not about making sure that they just are, intellectually mastering these skills. A lot of our clients are very bright. They're willing at times, and we want to make sure that what they're learning in session or in groups is something that they can take in the larger environment, because our clients live in the community. They go to school, they go to work, they have families, they have friends and romantic partners. These are all areas that they need to find ways of being skillful in. So remember, this is a very comprehensive treatment that has these 4 components. Anyone who says that they're practicing DBT has to provide individual therapy, access to weekly skills training group, phone coaching, and that therapist has to be part of a consultation team. A therapy that doesn't have all those 4 components could be DBT informed. They could be using some of these agreements, could be using some of these principles, but without these 4 core components, they're not actually practicing DBT. They're using DBT informed therapy. The individual therapy is essential because that's the place where patients can track these behaviors. They can have an opportunity to review with their therapist areas that they've agreed on that they would like to see progress in. The weekly skills training group is where the didactic portion of the treatment happens. This could either be a skills group attended solely by clients, or they could be a multi-family group that is attended by the clients as well as the families of these clients. The phone coaching is a very specific element of the treatment that's not seen in other modalities. These are inter-session contacts that the client is able to have by calling the therapist, and this usually lasts for 10 to 15 minutes. And the purpose of this is manifold. One is to ask for help, right? If the patient is facing a really distressing situation and would like help in real time from the therapist to address that distress. This allows a therapist to provide the kind of coaching that is tailored to the moment, that allows the patient to feel really supported and allows for better generalization, so that the training and the support aren't solely happening when the patient's regulated or solely happening in a controlled environment, but this is happening in the community at large. So the patient calls the therapist and can describe what is going on, what the source of distress is, and the therapist can recommend a series of skills that could be used in the moment. This is not a therapy session, but it is an opportunity to remind the patient of what the skills are and to give the patient a suggestion that they can then use in the moment. The phone coaching could also be used to obtain validation. Perhaps the patient isn't seeking skills specifically, but may need the coach to help them recognize and support their current situation in a way that feels validating and helps the patient feel seen. Phone coaching could also be used to repair the relationship. So if there's been a break where the patient felt misunderstood, had a hard time in therapy, the patient could call the coach and say, and have the opportunity to do a repair rather than wait till the next session. And lastly, phone coaching can actually be used for providing cheerleading or sharing good news, where the patient felt very skillful and was able to use their skills in a way and wanted to share this good news with the patient, with the therapist. Lastly, there's a therapist consultation team. One of the big issues with one of the big components of DBT is a recognition that we are all subject to a lot of these theories, that we also need support to treating a group of clients that are quite challenging. So the consultation team provides therapy for the therapist, provides support, allows the therapist to really lean in and stay engaged in the therapy in a way that allows them to be effective and to make sure that they're being aligned with the model. So key components, as we've discussed, number 1 is the dialectics. Number 2 is the acceptance versus change, which is a core dialectic of DBT. On the one hand, providing acceptance of what is, recognizing and validating the patient. On the other hand, providing and recognizing the need for change. And this is done through problem solving. This problem solving is allowing for that change in a way that is methodical, and is engaging the patient to look at what the vulnerabilities are, recognize what they can do in the moment, and really empower them to approach things differently. The states of mind, as we'll review later on, as well as the stages of treatment. The states of mind include wise mind, which is really a synthesis of the emotion mind, where a lot of patients can operate from when they're in distress, versus the rational mind that sticks to the facts, really leans into logic, but may not be so informed by the emotion that when synthesized together, it gives us the wise mind. And lastly, the stages of treatment that we'll review that really focus on initially forming that commitment all the way through stabilization and then creating that life worth living. So in dialectics, we're synthesizing these opposite ideas, or at least ideas that feel contradictory. We're holding this both and recognizing that things that may feel like polar opposites are actually part of the whole picture. So this allows us to see the wisdom in both sides in a way that allows us to not be judgmental and recognize where the patient is coming from. So when we're thinking about behaviors like self-injury, as I said before, the wisdom in it for the patient is that relief that's provided in the moment, right? The downside is everything that impacts their functioning. This reminds me, as a first-time mother of a toddler, I would drop off my child to daycare, and he often would cry in the beginning. He saw this separation as quite painful, and the wisdom in his crying was recognizing in the past, when he would cry, I would attend to him. I would make sure to stop what I was doing and maybe change course. So his crying absolutely made sense. Whereas the wisdom in my position, making sure that he was able to soothe and get back to daycare, was recognizing that this was part of his normal development. While we were both, while our focuses was different, this was actually important to recognize that we're both truthful and we had to find a middle path, which included finding a way to provide some soothing, but still being firm and bringing him where he needed to go. So this brings us to a few dilemmas, and dialectics exist everywhere. They exist for the clients, they exist for the parents, they also exist for the therapists. Because remember, there are things that may feel like opposite poles, but they're actually part of the whole, they're part of the reality. So for clients, this may be a state of active passivity where they're feeling helpless, they're feeling hopeless, they're having a very hard time generating the willingness, they're having a hard time getting past the shame or the guilt or the sadness that show up. In that state, what happens is we might, as their clinicians, feel compelled to act for them. They're taking a very active stance that may compel us to step in and do something for them. The opposite stance for clients would be apparent competence, where they appear much more competent than they actually are. So in one stance, they're very passive and pulling for our participation, pulling for us to do for them. In another stance, they may appear quite competent. They may come to our sessions and, assure us they've got this. They will never self-harm again. They have a great deal of insight. They may essentially overpromise and not have the maturity in that moment to recognize that they have these vulnerabilities which could interfere. So in this stance, they're taking on a role that makes them appear much more on top of things than they actually are. And it's not uncommon for patients to go between those two stances when the reality is somewhere in between, where in some instances they are quite capable, and in other instances they need more support. The goal here is to help them recognize that that middle path allows them to get the support they need, while also making sure we give them the freedom to show us where they're capable and the freedom to be much more masterful in their lives. Dialectical dilemmas that may appear for parents include: one is pathologizing normal behavior versus normalizing pathological behaviors. So, for example, having a teenager who frequently isolates in their room. On the one hand, if this is part of a behavior that allows them to recharge after school, that allows them to take some time for themselves before rejoining the family, this is normal behavior, especially during a time where teenagers are spreading their wings, they're becoming much more independent, they're taking time out for themselves. So this isolation may not be pathological, excuse me, but may be in fact a way to take space, and seeing it as pathological doesn't really encapsulate the reality. But if that same teenager was isolating increasingly at home to the point where they weren't participating in, say, family dinners the way they used to, they weren't participating in going out with peers, they were really spending time in their room in a way that was precluding other more adaptive ways, normalizing this would actually be overlooking behaviors that is pathological in that instance. And the goal here is to help parents recognize what behavior can be seen through that lens of pathology versus a lens that is actually developmentally appropriate. So bringing those two together gives us a much more accurate picture. And for therapists, one dialectical dilemma that needs to be resolved is, on the one hand, really engaging in environmental interventions. These may include hospitalizing the patient, right, to make sure that they're safe. These may include potentially rescheduling appointments very late in the day for a patient who has trouble getting up early in the morning, right? So we're changing things in the environment to accommodate the patient. Sometimes there's wisdom in that because it may provide more support for the patient. But exclusively approaching things from that pole actually doesn't give the patient opportunity to be more engaged and much more empowered in their treatment when we consult to the patient, where we're having the patient make decisions that are much more empowering and making sure that these decisions make sense for them. So that's the difference between taking hold of the treatment in a very directive way versus partnering with the patient. And the dialectical synthesis here is leaning into the environmental interventions when they make sense, and leaning into consulting the patient when that makes sense as well. That the reality is somewhere in between that really asks us to be flexible in our approach. So back again, that this main dialectic in DBT is finding that balance between that acceptance. So even in considering environmental changes, environmental interventions that could be quite validating for the patient, right? It's recognizing, the patient's having a very hard time right now. They need more support. That could be quite validating and accepting of their deficits versus pushing for behavioral change, where we're consulting to them and really pushing for them to engage in a treatment that recognizes their need for change. That coexisting of those ideas is really a way of recognizing that that's how we get to a much more accurate picture. So the specific strategies that we use here in terms of balancing the validation and problem solving, including DBT, specific problem solving strategies that are change-based. So this could include analyzing the behavior, and this is done through a variety of methods. We can do a chain analysis where we look at all the antecedents, all the factors leading up to that behavior, and we engage with the patient in looking at what led up to this specific behavior, what led up to the self-injury. That could be everything from noticing that they maybe had a hard time sleeping the night before, which made them more vulnerable, leading up to an argument with their mom about being late for school again, leading up to feeling hopeless and helpless and fearing the consequences, engaging the behavior, and then looking at the cost of this behavior. So analyzing the behavior is a strategy that is very change focused. And of course, committing to change and taking specific steps to change, which may include focusing on reducing these vulnerabilities, which may include making sure that they're attending to their sleep needs, making sure they're attending to eating balance, making sure they're avoiding using substances that could all make them really vulnerable. And this is different from the more validation strategies that are really focused on helping patients understand and recognize their emotions as valid. So the other area that we wanted to consider is, as we had talked about, these states of mind. Marshall had recognized that many times patients operate from a place of emotion mind, that their responses are usually in response to the stress when they're very heightened. And a lot of these behaviors are focusing on relieving that distress. And a lot of the information there comes from the emotions. And there's wisdom in this because emotions do provide us with information. Anger may reveal what's important to us. Sadness may be an opportunity for us to validate a loss that we've had. And anxiety is a great way to raise the alarm and helps us recognize what is dangerous and how to stay safe. So the emotions bring with them a lot of information, but making decisions that are solely from that emotional state doesn't bode well and is often leaving out an important part of the picture. Versus a more rational mind state where the decision making comes from solely focusing on logic and data points that are very cold and don't take into account the information that emotions are providing. And Marcia recognized that a much more nuanced, effective stance would actually include both of those places where we can use the strength of logic while also using the information provided to us by the emotions that we're experiencing. And this is where the wise mind happens. This is the synthesis of those two states. So with that in mind, the stages of treatment include the following. So we want to make sure that we follow a very specific method that recognizes what is most important. Initially in pre-treatment, this is where patients are making a commitment. They are recognizing that their lives, as they're living it, is not tenable, that they're suffering a great deal, and they need to make a commitment where they would ask for help and engage in the treatment as a whole. The next stage, once that commitment is had, is the civilization, is attending to those life-threatening behaviors, addressing those self-injurious behaviors, addressing the suicide attempts, addressing the suicidal ideation. This is where the civilization occurs, where a lot is invested in validating their suffering, but also really encouraging them to be curious about how they arrive in places that lead to those attempts or lead to the self-injurious behaviors. Excuse me. The next stage is in allowing for patients and clients to really fully experience their emotions. Once they're stable, we can attend more to that full experience of emotions and also attend to trauma if that is part of the picture. It is not uncommon for patients who need DBT to not just have PPD, but also have a ton of co-occurring disorders, including trauma. And one of the ways of addressing this is making sure that we have a period of stabilization before attending to a trauma, because if we attend to a trauma first, we may be flooding patients and getting them to a place where they haven't yet mastered the skills, and they will be exposed to a lot of distress that may then lead them to act on this distress in really ineffective ways. So once we've guided them through, excuse me, fully experiencing those emotions in a way that they've gained mastery of those skills, we can work on building that life worth living, allowing patients to really incorporate their work and their school and focus on what it is that they want to stay alive for. This treatment is not so much suicide prevention as much as it is giving patients a place that gives them a different option so that suicide or self-injury doesn't become the only option or isn't the solution. We're giving them ways of addressing their suffering that builds that life worth living. And lastly, during the stage 4, we want to create meaning where patients feel much more fulfilled. We address the emptiness, the boredom that may arise, and that sense of fulfillment that they need to keep going. Excuse me. So just as patients have agreements and commitments, the clinicians who treat them also have agreements. So the first one being the dialectical agreement, where clinicians recognize that they have to hold these opposite views, that they're committed to looking for what's missing, that when they're feeling very certain about their position, that the onus is on them to recognize what is the wisdom in another person's position, what is the wisdom in my position versus another's position, so that they can have a much more complete view of what's happening. This is especially important when clients and clinicians are at odds, or sometimes even clinicians are at odds with each other. And this agreement helps them recognize that there's wisdom in that disagreement, that each person brings with them a position that has wisdom that needs to be considered. The next agreement is a consultation to the patient, where the clinicians recognize the client's autonomy, the client's capacity, without treating them as fragile, excuse me, and engages them in a way that is respectful and dignified. The consistency agreement is helpful in recognizing that we don't all have to approach the patient similarly, that we can all be effective in our own way, and that the only time the consistency agreement, we have to be consistent in terms of approaching a patient similarly, is if we've agreed upon a specific behavior plan. Now, this is important, say, in a residential setting or hospital setting, when a plan has been created and the consistency matters. Outside of that, each clinician brings with them their experience and their wisdom that allows them to approach a difficult situation in a way that makes sense, that doesn't have to be exactly the same as another clinician's approach. And along those lines, we also agree to observing and respecting each other's limits, that on the one hand, we recognize that we each have our limits. My limit could include making sure that I am available for skills coaching between the hours of 7 a.m. and 11 p.m. And between those off hours, the client knows that they can seek help elsewhere. Now, that's my personal limit, and another clinician may have a totally different limit. They may be available 24/7, and that makes perfect sense for them, and there's wisdom in both positions. Now, while we observe our limits, we also recognize that it's sometimes okay to push or stretch those limits, that there's wisdom in that as well. So if I've had a client who really had a hard time asking for help, and they finally reached out, say at 11:05 after the time, I might stretch that limit to maybe reinforce them asking for help. If that's the first time they've asked for help, that I'd like to reinforce them reaching out and say, and increase the likelihood that they would reach out later on. Next, the phenomenological empathy agreement. Try saying that 3 times. This is actually one agreement that's helpful to keep in mind because it reminds us to maintain empathy for each other when we see a behavior that we do not maybe understand or agree with, and we try to hold on to the best case scenario. So if I saw a behavior in a patient or a behavior in a client, in a clinician, that if I don't have a good explanation for it, then my default position isn't to be critical, but my default position is to assume that they're doing their absolute best. So one example of this that I experienced very early on was my first year working in a DBT residential. I had agreed to do a training session with my supervisor, and this training session was meant to start at 9 o'clock in the morning, and I got into a car accident. And I remember sitting there as the clock ticked. It was like 8:45, 8:50, 9 o'clock. And I was terrified that my supervisor was going to assume that I didn't take this seriously, that he would have all these critical ideas about me. And I remember meeting up with him after the fact and saying to him and expressing my regrets about not being able to make it to the training. And he said to me, well, in the absence of information, I'm going to assume that you're doing the best you can. And he added another piece of this, and he said, if I assume that you weren't, this would actually create more suffering for me. So this was actually an important lesson for me going forward. Lastly is the fallibility agreement, where we agree as clinicians that we are fallible. This is important because this allows us to move away from a defensive stance and to a stance that recognizes that we may very well and most likely have done some part of what we are accused of doing, so that we're less invested in defending ourselves and much more invested in being effective and moving forward. Now, in terms of commitment strategies for the patients, excuse me, there are quite a few because we use a variety of ways of really building motivation for the patient. So we want to maintain motivation for the clinicians in the consultation team, but we want to use commitment strategies to maintain motivation in that pre-treatment phase, but we also use it throughout the treatment. So a few include doing pros and cons, and this could include helping the patient think through what are the pros and cons of maintaining a behavior. That behavior could include everything from self-injurious behaviors, restrictive eating, using substances. I usually start off with the pros of the behavior as a way of communicating to the patient that I recognize that there is some value in that behavior, even if on the surface that behavior seems problematic. So I have the patients share with me what the pros are of that behavior, and then have them generate what are the potential cons. Excuse me. What are the potential cons? This is important because it helps the patient then hold both sides and helps them be more likely to engage in committing to changing the behavior, because they realize that you see how the behavior is helpful and they can then hold how the behavior is ineffective. Another strategy includes foot in the door. This is where you make a small ask. For example, can you not self-injure for 24 hours? Or can you not self-injure for a week? Patients are much more likely to agree to bigger commitments if they've agreed to smaller ones to begin with. So if we can agree to maybe 24 hours or a week, we can build from there and include maybe a month and go from there. Conversely, we can ask for something that is so big, and knowing full well that the client might say no, that they're more likely then to agree to a smaller commitment. So that's door in the face. So we might say, will you agree to refrain from using cannabis for a year? And that may be too much for the patient to consider. But then if you say, well, okay, let's settle for a month, or let's settle for while you're actively in this stage of treatment, patients are much more likely to say yes if they've had to say no for the previous ask. And in terms of motivating patients, we can use past commitments to engage them in newer commitments. So, for example, we can remind patients that in the past they were able to hold their commitments, and we engage with them by saying, look, what have you been able to do in the past that you committed to and you were successful in doing? Now, can we use that same data point? Can we use those same strategies in this place? We can also cheerlead them and provide them with encouragement, and sometimes even play devil's advocate, right? So this is an important one. Even after clients have agreed, say, to, okay, I'm not going to self-insure for a month, but we can sometimes test that commitment or even strengthen it by using devil's advocate and say, okay, well, what's the, excuse me, what's the wisdom in giving up self-injury? And have them make the case for it as a way to strengthen that commitment. We can also look at freedom to choose in the absence of alternatives. So if patients have to choose between, say, going to inpatient or going to an IOP or having to commit to more frequent therapy sessions, they may not want either of these options. But giving them the freedom to choose even between options that are not really palatable may help them commit. So yes, there's no palatable alternative, but giving them that freedom actually helps them feel much more empowered to commit. So once we have that commitment, we can then use a treatment hierarchy to first address the life-threatening behaviors, which include the self-injurious behaviors, the self-injury and the suicidal behaviors. And then we can use our time to reduce treatment interfering behaviors. Treatment interfering behaviors can include coming late for therapy sessions, not doing their homework, refusing to engage, shutting down. But it's important to remember that therapy interfering behaviors could happen on the client's part, but they can also happen on the therapist's part. And we will review those in a little bit. We want to reduce quality of life interfering behaviors. Once we've addressed life-threatening behaviors and the therapy interfering behaviors, the quality of life interfering behaviors include things like potentially restrictive eating or even using substances that, while may not initially pose a threat to their life, but could really interfere in their capacity to maintain a job consistently or maintaining important relationships. Lastly, we want to increase our ability to acquire these skills, especially out in the community. So we want to reduce these life-threatening behaviors that include the suicide and a non-suicidal self-injury, while also reducing those quality of life interfering behaviors. So the treatment interfering behaviors, as I said before, are the ones that really undermine the treatment. So it could be not completing homework, but could also be behaviors that are done by the therapist. I'll say one thing about the shaping behaviors. So this is where therapists can shape behaviors of the patient by gradually encouraging small middle steps that lead to big changes. But clients can also shape therapist behaviors. For example, if a therapist finds that when they engage in a certain topic, the client shuts down, the therapist starts to avoid certain topics. And thereby the client starts shaping the therapist away from addressing those behaviors. That's an example of shaping that could actually be therapy interfering. So we will look at the skills acquisition. And as I said before, recognize that this functional behavior is in fact functional for the patient in a way that addresses their distress in the moment. Going to speed up a little bit just to make sure that we address this. Excuse me. So these core skills that we use in treatment include distress tolerance. These are skills that can be used in the moment when talking through may not be really advisable. So for example, the stress tolerance skill might be intense exercise. So that might be running up and down the stairs or using an ice bath to the face, anything that brings the temperature down, that brings the intensity down in the moment, that doesn't require higher order levels of thinking. The next core skill is mindfulness. This is an important skill because it helps the patient observe their thinking, observe their behavior in a way that allows them, if they're able to really practice the skill when they're regulated, it allows them to then be able to do that when they're dysregulated. And the next skills include the interpersonal effectiveness skills. These are skills that are geared towards methodically helping patients recognize how to stay engaged in a way that's effective in relationships that include give, where they act interested, they're gentle, they provide validation, versus using their fast skills, which require them setting limits. So these are ways in which patients can look at how they interact in their relationships to maintain them effectively while maintaining their self-respect, but also recognizing that they need to be practiced. And lastly, problem solving. These include ways of approaching a problem, everything from recognizing that they can decide not to solve the problem and just fully experience emotions to potentially making it worse, or using specific skills to address their distress. So what this looks like from inpatient care to community care is recognizing what lands people in the hospital. And DBT can help prevent these hospitalizations by reducing the emotional reactivity, reducing all the behaviors we've talked about, and increasing self-awareness, increasing their ability to apply these skills across context, and really allowing patients through that dialectical thinking to accept life as it is, to accept essentially both the parts that are helpful, that are pleasurable, that are tolerable, and the parts that are painful and aversive as a whole. So in the community, DBT can allow patients to apply these skills in the real world. They can help build relational skills. They can allow patients to see, here's what happens when I use these behaviors at school, when I use these behaviors with family, when I use these behaviors with peers. The downside of being in the community is there are more risk, there are more likelihood of experiencing more stress and triggers, honestly, that could interfere with them practicing the skills initially. Conversely, in an inpatient setting, there's limited opportunities to practice these skills in real time, but it is an opportunity to provide for more stabilization. So in the inpatient setting, patients get more support. This is a much more environmental intervention that helps support them and is much more validating versus a setting outside of that in the outpatient world that may be more change focused, maybe much more focusing on helping patients use their skills in real time. And most important, it helps to generalize the skills so that clients aren't simply using these skills in a setting that's just in the hospital setting or just in the clinician's office setting. So one way to really engage the system is to make sure that there's a lot of collaboration between the inpatient side and the outpatient side, that there's a lot of structure that's built in so that when clients return to the outpatient level of care, they're given the opportunity to recognize what's been useful in one setting and what they've learned and bring it to the next setting. This also includes working with their psychiatrist and making sure that there are not power struggles around managing the medication. Something simple as making sure that clients have access to maybe a couple of days worth of their medications supervising this, then using a cassette before then gradually working to having clients have access and more freedom around managing their medications. So we think about this, how does the family, the school, and the clinical team all come together to make sure that they're reinforcing behaviors that are helpful while also making sure that they're pushing for change in a way that is tolerable to the client. So we do this by engaging the patient, validating them when we can, and also pushing them for change with providing them with specific skills. So here's an example of a case that I had, and we'll call her Linda. She was a 17-year-old who was in danger of repeating the academic year because she had a really hard time making it to class. She had previously been treated for depression and anxiety. And her therapist thought, could this be BPD because of all the other areas in which she was struggling? She had intermittent bouts of self-injury, previous hospitalizations because of suicidal ideation. And in addition to the self-injurious behaviors, she was using things like cannabis, restricting food at times, and really having a difficult time maintaining relationships with patients. The most recent thing that led her to a consultation was essentially losing her old friend group. During her bouts of hospitalization and her bouts of self-injury, she would reach out to her peers, and the peers felt quickly overwhelmed, and slowly but surely, all these relationships suffered. So when we look at how this impacts these various parts of the system, the school, for example, attempted to accommodate her. They had a counselor ready for her to see when she was really stressed out. And that didn't really address her difficulties attending school because she quickly felt overwhelmed with the work. And instead of reaching out for help, got really self-critical, felt a lot of shame, and anticipated that the school would criticize her and really get on her case about not showing up for school. So she wouldn't show up, the work would pile, and then she would miss even more days. The outpatient team, in recognizing that they were essentially in a loop where she would do okay, but then end up with multiple hospitalizations, worried about her safety, and even thought about discharging her from their care. The parents, on the other hand, felt quite stuck because they had a lot of insight into what was happening, but they really felt like they didn't have the tools to move forward. And she herself had a really hard time managing what she described as impulsivity. The impulsivity here was noticing for her that she would feel very anxious or very empty and would reach out to her peers as a way of addressing her distress. They felt overwhelmed, and if they didn't respond in time, she would then self-injure. So I'd like to pause there since we're running out of time and consider some of your questions.
Thanks so much, Sophia. Hold on, that was so great. I feel like this was like such a great introduction. We definitely have some questions from folks in the chat. I feel like we got a lot of questions about what and this I'm sure is also, you're working out of Massachusetts, and I feel like this is maybe something that's state by state, but sort of what work there's being done about making DBT more accessible. I feel like this is, a big question I know that a lot of folks have because it's a very sort of high investment kind of treatment. And so maybe for folks who are wondering, I think I'm wondering also how folks can sort of take what you're talking about and maybe integrate it into their settings. I don't know if you can answer questions maybe about like why insurance doesn't cover it, but maybe what we could think about instead was sort of how folks can take pieces of this and integrate it into what they're doing maybe at the sort of community level so that patients can benefit from it.
Yeah, I first of all, it's that may be for a different discussion, but it is really sad that insurance doesn't cover this, and we haven't found a way to make this more affordable as well. I will say though, in terms of like using this approach in this setting, it's really important to take to heart being curious and keeping in mind that there are behaviors that we engage in, that the system engage in, that could reinforce the problematic behaviors of the clients. And one way of stepping back is actually recognizing that what we're seeing is a result of a variety of factors. So applying this means being curious. If you have a client that you feel stuck with, if you have a client that you feel you've done everything for, maybe take a step back and asking, what am I missing? And really engaging with the patient in a non-judgmental, non-critical way that allows them to step by step think about what contributed to what we're currently seeing. So if nothing else, using a very curious, non-judgmental stance goes a long way in recognizing how we're contributing potentially as clinicians, but also how the patient's contributing in what's currently happening. There's a lot being done and also including DBT in schools and in other settings as well. So even if we can't make it accessible to everyone for a variety of reasons, that include insurance or not making it more affordable, is that in other settings where mindfulness practices and practices that really focus on being curious and open-minded and looking at dialectics in a way that looks at the wisdom and opposite sides can be useful going forward.
Fantastic. Um, I feel like we have a question here about how can DBT assist when working with willful or resistant clients? So maybe this is both potentially clients that are not ready for change, or also maybe clients who are maybe not really ready for treatment at all, or who maybe are like more reluctant to engage in treatment.
Yeah, so we see a lot of willfulness and a lot of resistance, right? And sometimes I tell my clients that, engaging DBT sometimes feels akin to, it's winter and I have this coat, and you're asking me to take this coat off and walk into a snowstorm, but have faith that you're giving me the tools to stay warm and stay protected. Because that coat is really all the behaviors clients have used to navigate the world. It's not perfect, but it's what they've had so far. So they would absolutely be resistant to change because they're doing the best they can with what they have. So resistance makes sense and willfulness makes sense if we realize that what they're using, as problematic as it is, those are the solutions they've come up with to navigate their distress. So one way of addressing that distress is first and foremost validating how much they've suffered and validating how difficult it is for them to relinquish these behaviors that have served a purpose up till now. And lastly, recognizing that a lot of willfulness for us who practice DBT is actually fear. So many times when people are willful, they're terrified. They don't want to give up something that has worked so far. And that's the dialectic, because it's working and it's not working, right? The behaviors that they're resistant to give up works in the moment, and it's not working because they're incurring pretty significant long-term consequences. So I really rely heavily on the validation initially to think with them, look, this makes perfect sense. You've been through so much treatment. You've had all these losses. You've incurred all these consequences. It makes sense that you would want to give this up. And sometimes hopelessness, aside from fear, can really be fueling that resistance, because why would I engage in a treatment if I don't think it's going to work, right? So if hopelessness and helplessness aren't addressed, we will not have a chance at reducing that resistance.
Amazing. Yeah. And I see folks in the chat really liking that metaphor of the winter coat. I also am seeing folks here who are maybe doing more community-based work, things like sort of ACT teams or IMT teams, and they're asking about sort of the best way to collaborate with DBT providers to support client growth. And so I feel like this really speaks to what you were talking about before about sort of maybe the best way that an outpatient therapist or a community-based therapist can work with folks on the inpatient to sort of create that balance. And I know you and I have talked about that a lot, about sort of how that sort of bringing those skills into the real world, but also then making sure, so I was wondering if you could speak to that a little bit as well.
Yeah, so part of this is recognizing the role of each of these components, right? The inpatient provides some stabilization and safety, right? And for some patients, it can serve the function, unfortunately, of avoiding, right? So while we're looking at it as a way of stabilizing our patient, they may see this as a way of stepping out of their lives when they're getting overwhelmed, right? And part of this treatment is helping the inpatient team not be so reinforcing. And sometimes that may mean telling the outpatient team maybe not to visit the patient while they're inpatient, or not have too much contact with them, because we don't want to create a situation where the patient has the experience of avoiding and getting the benefit of that warm, supportive relationship, but really helping the patient recognize that if they want to maintain that relation, if they want that support, the best way to get that, excuse me, is to work to be discharged, is to remain in the community level of care where they can be best supported. This may mean working with the inpatient team to make sure that they're not engaging behaviors that could potentially be reinforcing with the patient, that could be making that inpatient stay honestly much more comfortable and reinforcing than it needs to be. So sometimes, at a really concrete level, if we had a patient who prefers one specific inpatient unit, and I realize I'm saying this when we don't have a lot of resources, we don't have a lot of beds, but sometimes patients can have a go-to unit where every time they're hospitalized, they end up in that unit where they know all the staff, they're friendly with the support people. And one way to address this might be to, next time they need to be hospitalized, actually sending them to another unit, so that while they're getting that stabilization, it's honestly a bit aversive enough so that they're much more motivated to stay out of the hospital setting. This may also require sometimes the opposite could happen, where we use the outpatient team to give the patient more support while they're inpatient, to give the patient some homework, use that as an opportunity to recommit, right? So while they're inpatient, have them do some analyzing of their behaviors to figure out what could the outpatient team do differently to help the patient be more skillful before laying into hospitalization again. So that way we can use that in hospitalization as a bit of a timeout for both the clients and the clinicians, to make sure that we have new pieces of information we can use going forward. Because it could be that the therapists themselves were engaging therapy interfering behavior, or maybe it was more on the part of the client.
I can also see that being really useful for helping not reinforce the avoidance, if by including that therapist, it's like you're reminding the patient, the client, that like that life outside of the hospital doesn't actually stop. And so it's not really truly like I can pretend that my life outside of here doesn't exist, right? We're gonna continue to have, thinking about like what do those skills look like? What are the skills going to look like in the future when I do leave?
Absolutely.
Yeah. So we have I feel like two more questions. One, we have Doris Cervantes, who's given us a sort of a little bit of a picture of a patient that she's seeing about who is engaging in self-harm, and talking about how can you sort of talk to a client about a sort of safer way to self-harm. And I feel like this is really getting at a conversation you and I had earlier this week about or maybe it was last week, about the intersection of harm reduction and DBT. And I was wondering maybe if you could speak to that, because I found that really enlightening when you talked to me about it.
Yeah, so I mean, it's an interesting take, right? Because on the one hand, we could say that not, there's on the one hand, freely self-injuring is one end of the spectrum, and not self-injuring is the other, right? And that the dialectic would be to find a safe way of doing it. I don't think that's the case. First of all, perpetuating that behavior, we know, increases the likelihood of people attempting suicide as well. People who self-injure are also more likely to attempt. So just on a very, in terms of safety, that's something that we want to absolutely work on minimizing versus perpetuating. One way we try to use, I guess, that more middle path approach is recognizing that you can simultaneously make the commitment to not self-injure while recognizing that you are at risk and you are vulnerable to self-injuring. and really become invested in reducing those vulnerabilities. So we're not asking for perfection, we're asking for the willingness to, one, be curious about what makes you more vulnerable to it, two, a commitment to really ask for help when you're struggling, and three, a recognition that there are factors that make you more vulnerable, that it is your commitment to address them to reduce the likelihood of that happening, right? So, there's DBT that's been modified for, say, substance abuse disorders, right? And one adaptation of that is using clean mind versus, which is clean mind, where it's, I'm never going to have a drink again, I'm all cured, I'm all better. And on the other hand, there's addict mind where it's hopeless, I'm always going to be drinking, there's no use in stopping, I'm just going to continue this behavior. When in fact, in the middle, what's akin to wise mind is sober mind, where there's a recognition that I want to stop drinking, and here's what I need to do to reduce the likelihood of that happening. So I'm acknowledging the risk, I'm acknowledging the vulnerabilities that allows me to work on this. So that may mean if I'm stuck in clean mind, I may say, I'm never going to drink, but then I walk into a bar, right? And I walk into a bar after having a really difficult fight with somebody I really care about. And I'm not, because I haven't assessed the risks, I haven't prepared for this, I'm much more likely to engage in behavior. So if I'm in sober mind, I recognize, okay, if I have to be in a situation that increases the likelihood, what can I do beforehand? Maybe I have a session beforehand. Maybe I cope ahead with my therapist. Maybe I don't go to that place, but if I do, will I go with a partner? Will I go with somebody who makes sure that I stay on track? So the way of reducing the risk is analyzing it and recognizing it versus saying, I'm going to keep perpetuating the behavior.
Yeah, I think that's great. I think it's one of those things where it's like putting all those contingencies in place and also holding things at once, right? So I'm not going to engage in self-harm, and I understand my risk, and I know that maybe, knowing that I have that risk, not being around, like acknowledging that like having dirty like sharps are going to put me at even more increased risks, right? So knowing that, okay, like, and I'm going to commit to not doing it, and to commit to not using things that are going to increase my chance of developing an infection. So I feel like all of those things can be held at the same time, and that's where that dialectic comes in, right? Like being able to hold those things all at the same time.
Absolutely. And that may mean that ahead of time, so for example, while a patient's in hospital, that may mean calling their parents and saying, look, can you look into my drawer? I have this implement.
Yeah.
Making sure that before they get home, they've asked for help in the form of having things removed,
Yeah.
or going home on a pass or a visit, while making sure that while they're regulated, that these things are taken care of. So they're not waiting when they're dysregulated, where the risk is much higher for them to act on the behavior, on the impulse.
Yeah, that's great. Well, I have a couple of folks here asking about modifying DBT to address the needs of younger children, so preteens or even maybe school-age kids. I'm wondering if you could speak to that at all.
Yeah, there is some work being done actually to work with younger children. On the one hand, if on the surface DBT can feel like this like very concrete manualized treatment where like there are all these acronyms, if this then that, but it's actually a treatment that requires quite a bit of sophisticated thinking. So normally most people who engage in this are either adolescent or young adults or older clients. But there are modifications for DBT. I think it's called DBT child actually, for younger patients.
Yeah, I can imagine that, as when we are younger, we are much more black and white in our thinking just developmentally. And so that being able to hold the gray is sort of like really hard when you're a kid. And so that is a nuance that is sort of, we're looking for folks to have as a part of DBT. And so developmentally, I feel like you would, there's a reason why, younger kids might struggle with it a little bit more.
Absolutely. Same thing with the commitment, right? So one thing that we really struggle with is in adolescence, adolescents can be very intellectually advanced, right? And we know their prefrontal cortex isn't fully mature. So they're right. So they have this capacity to hold a lot of information in. And where they're most vulnerable is in this capacity to think about the long-term consequences of their behavior, really recognize and do a risk assessment that makes sense, right? So from the get-go, without any pathology, it's perfectly developmentally appropriate for clients who are adolescent to struggle with this. So there's a lot that needs to be done in recognizing that vulnerability. So when we're using these commitment strategies, we do have to think about who we're talking them into.
Oh, Sophia, it looks like you're frozen. Leslie, are things frozen for you too? I just want to make sure it's not my computer.
Yeah, she's frozen on mine as well.
Okay. Well,
Maybe give her a second.
hopefully things come back. I know that there were some weather issues where she is. Thank you all so much for your questions. It seems like folks also are asking about the possibility of a follow-up. So we'll definitely be following up with Dr. Maras about potentially offering a follow-up. It looks like maybe she lost connection there again. Given that it's 1:50, I feel like if folks have any more final questions, you can definitely put those into the chat as Dr. Maras is potentially trying to get connection back. We will do some wrap up while we're sort of here and have some time. So we have some more resources here, some online resources. Again, we'll be following up with Dr. Maras about potentially doing a follow-up for about skills application. But you can look up some some different resources here. And again, these links will be available to you because we're going to be posting our slides within 2 to 3 business days. So I know a bunch of folks were asking about that in the chat. We're also going to really encourage you all to come to our some follow-up events in the new year. I know that, it's 2023 is coming to a close very rapidly. So these are mostly going to be in the new year, but we're going to have some offerings for family peer advocates, but also just how to facilitate family peer support groups. So we hope that will be on January 12th. For youth peer advocates, we're going to have an offering on the role of YPAs in residential settings on January 19th. We're also really hoping that folks will listen to our CTAC podcast, which is called Voices from the Field. So we really hope that you all will check that out. There's already a couple episodes out, but you can find it at ctac.org/series to listen to. And then you can access it also on Spotify and Apple Podcast. And then this isn't on the slide here, but we're going to be doing an offering. The registration hasn't gone out, but in late January also on aggression in children, violence and aggression in children. So I believe that'll be around January 25th or 26th. So keep an eye out for that. You'll get a registration email as well. Thank you all so much. It looks like maybe Dr. Maras is having some issues reconnecting. So if there are any other questions that we did not get a chance to answer, please feel free to email us. I know that our email is in the chat, I believe. And also, again, please take a second at the end to do our survey on that will, there she is. She can maybe give us a final couple of words before signing off.
Hey, Jackie, I'm so sorry. I lost power.
No worries. No worries. We were just doing all of our final wrap up business. So we took that time to get that out of the way. So if you have any sort of last comments or last thoughts before we wrap up, I thought we'd give you the chance to do that since we're almost at the end anyway.
Yeah. Well, thank you so much for that, Jackie. No, I wanted to open up for if there are any more questions. Maybe it's time for one more question.
I think looking at our questions, I feel like we got to do most things. It feels like a lot of folks are interested in potentially having a follow-up presentation specifically focused on applying DBT skills in an outpatient setting. And so I said that we could discuss that with you as a potential for a future presentation. But I think that we're good in terms of further questions. I guess, yeah, any last thoughts that you wanted to share or?
Well, I'm really grateful for any opportunity to talk about DBT, and my hope is that people get more interested, invest in getting the training where they can, and really applying these principles. It doesn't have to be part of a comprehensive treatment, but I think a lot of these principles can be applied in most any treatment. And last thing I'll say, it's also one of the few modalities that really require clinicians themselves to integrate it in their own life. DBT isn't just something we deliver to clients, but it's something we practice as well. So I will share that I had to practice a lot of my own distress tolerance around the electricity going out a couple of times, and noticing how it was impacting my ability to be present. So I appreciate the patience with this.
Yeah, no, it was planned. It was a real life example to show us all how these skills can work. We just wanted to give a live demo. But no, thank you. And yes, I feel like that's one of those things that I think is so important. We bring ourselves to our work. And I think that one of the things I love about DBT is that it really asks us to examine exactly what we're bringing to the work and taking steps to walk the walk, in that we're asking our clients to work, and to sort of practice those skills ourselves. I see some folks are saying that their link isn't working for the survey. So if you're not, for some reason, I think sometimes when folks are like on a phone, it doesn't always work, but if you're not getting it pop up, it'll be emailed to folks. So you can look out for that in your email. Thank you all so much for coming today. We really appreciate all of your thoughts and questions, and we'll hope to see you all at future events.